Welcome. Thank you so much for joining us this evening. Tonight, we bring to you the first of our Empowered Patient Education webinar series in honor of Colorectal Cancer Awareness Month. I'm joined tonight by a few of my colleagues, including our tireless leader, Filomena Servideo Italiano, who is CRAN's President and CEO. Filomena will say a few words just before we get started.
Thanks very much, Cassandra. Well, good evening, my friends, and happy Colorectal Cancer Awareness Month. We are absolutely delighted to be hosting you this evening. I just wanted to extend a very warm welcome. Tonight is all about you. This entire month is all about you. Everything that we do all year long is all about you. But I just wanted to ensure that I warmly welcomed you this evening, and stay tuned because we have a very exciting session dedicated to the management of colorectal lung metastases. You're in for a super wonderful session that's being delivered by Dr. Marcelo Cypel. So thank you. Thank you for joining this evening. Back to you, Cassandra.
Thank you so much, Filomena. So tonight's webinar will be moderated by Himanshi Singhvi. Himanshi joined CRAN as a student intern about a year and a half ago, and right away it was just evident how very special she is. After graduation, Himanshi joined our team full-time in the capacity of National Programs Officer, and she has been integral to the launch of our My Cancer Companion program and works passionately to ensure our patient-focused programs and resources get to those who need them. Over to you, Himanshi.
Thank you so much, Cassandra, for the lovely introduction. And hi, everyone. Thank you so much for joining us tonight. I know it's quite late for some of you. I'm just going to share my screen really quickly. Okay, I hope you all are doing well. I am delighted to start off with our very first Empowered webinar series today, hosted in honor of Colorectal Cancer Awareness Month, as Phil mentioned. I just wanted to take first a quick moment to introduce CRAN, as I know we have some newer members in the audience that may not be as well acquainted with us. So, the Colorectal Cancer Resource and Action Network, more affectionately known as CRAN, originated as a grassroots colorectal cancer information and support group back in 2006, after the passing of our founder's father. Today, CRAN has proudly become a national, not-for-profit, patient-focused organization. We are governed by an experienced board of directors and are counseled by an expert medical and scientific advisory board. At CRAN, we have 2 patient advisory councils, and their perspectives and past experiences with the disease actually inform our program development to ensure our programming and services are relevant and meaningful. In terms of our mandate, we champion the health and well-being of Canadians that have been touched by colorectal cancer and others that are at risk of developing the disease. And we do this by providing support, education, and advocacy to patients and their caregivers to help improve patients' quality of life as well as their longevity. CRAN has expanded its patient-focused mandate to serve multiple tumor type patients through our HTA patient evidence submissions, educational events, advocacy initiatives, and now our patient programming to ultimately reduce the burden of cancer in Canadians. I'd also like to take a moment to quickly mention that registration for BumRun is now open. For those of you who don't know, BumRun is a 5-kilometer walk or run event that is dedicated to raising awareness and encouraging screening to prevent colon cancer. This event is CRAN's primary fundraising event, and any and all funds generated from this go solely towards supporting CRAN's patient programming. We implore you to consider registering for BumRun in a city near you or virtually, or kindly consider donating if you're able to. And finally, we're in March, which is Colorectal Cancer Awareness Month. In honor of this, CRAN is hosting a number of events. This includes the We Wear Blue for You campaign, which took place on March 3rd, and we actually also have our Blue Hearts campaign, which is taking place tomorrow. If you want to get involved, you can share our Blue Hearts image as a simple yet powerful way to raise awareness about colorectal cancer and honor all of those that have been impacted by this disease. This month, we are also, of course, hosting the EmpowerED Patient Education Series on every Thursday of the month starting today. Before we get started, I'd also like to go over a few reminders for today's webinar. First, Kindly keep your mic muted during the webinar itself. Dr. Cypel will be accepting questions from the audience at the end of his presentation. If you have any questions, you can submit them either through the Q&A function or the chat function during the webinar, or you can raise your hand at the very end of the webinar and you will be unmuted to ask a question. Finally, I'll also note that today's patient education session is being recorded. The link to this recording will be sent out via social media and email to all the registrants after this session to make sure you can access and view the recording after. And now for the part that you've all been waiting for. Today's session focuses on the novel surgical approaches for the management of colorectal cancer lung metastases. Of the patients that are diagnosed with advanced stage 4 or metastatic cancer, one of the places colorectal cancer is most likely to spread to is the lungs. Tonight, Dr. Cypel will address the advancements in management of colorectal cancer lung metastases and the potential impact of these approaches on patient health and quality of life. The current innovative clinical trials transforming the landscape of cancer care, including the deceased donor double lung transplant and the in vivo lung perfusion trials, will also be highlighted. Following this presentation, as I mentioned, you will have an opportunity to ask Dr. Cypel all of your burning questions. With that, I'm pleased to introduce Dr. Marcelo Cypel. Dr. Cypel is a staff thoracic surgeon at University Health Network and a professor of surgery at the University of Toronto. He's the surgical director of the Ajmera Transplant Center at UHN and artificial lung program also at UHN. During his postdoctoral research fellowship, he developed a new method of lung preservation and donor lung repair called ex vivo lung perfusion. This method is now used clinically in Toronto and in many other centers and has significantly increased the number of transplantable lungs. He subsequently performed a 3-year fellowship in thoracic oncology, cardiac surgery, and lung transplantation at the University of Toronto. His main clinical interests are in artificial lung devices, ex vivo and in vivo lung perfusion, and lung transplantation. Dr. Cypel currently holds the prestigious Canada Research Chair in Lung Transplantation from the Government of Canada, and he is the principal investigator in very innovative clinical trials, such as the use of uncontrolled donation after cardiocirculatory death for lung transplantation and an in vivo lung perfusion with chemotherapy to treat patients with lung metastases. He is a member of the American Association for Thoracic Surgery and a fellow from the Royal College of Physicians and Surgeons of Canada. And with that, I'll hand it over to you, Dr. Cypel.
Thank you. Thank you for the kind and long introduction. So welcome, everyone. I know it's a bit late, so thank you for staying at this time of the day. Let me share my slides here. I think you can see. Yeah, it's good. Okay. So I'm just going to talk about what's new in lung metastasis. I don't have any disclosures related to this presentation. And there are maybe some of you that have seen many content of this presentation because I presented a few months or maybe 6 months ago. And although there are a few things new, I would like to keep it the overall content here, and some of you haven't seen yet. So I would like to start from the basis a bit, and then we go from, what are the new, technologies and potential studies. So whenever we see a patient with pulmonary metastasis from colorectal cancer, the first thing we ask is whether the local therapy is going to be helpful, and if so, what would be the best modality to use. We have surgery, SBRT, there are conventional radiation, radiofrequency ablation. But I would say that for the lung, at least in North America, the most used modalities are surgery and SBRT. In Europe, they use more radiofrequency ablation. It's a more invasive procedure. And I think SBRT has probably better results, and that's why I think we take preference on that here. Depending on several features such as the age and comorbidities, the pathology of the primary tumor. And I think the timeline of the disease course is important. What we call disease-free interval, how long after the primary tumor was discovered that the disease has appeared in the lungs. Of course, the shorter that interval is, the prognosis is more difficult. The rate of growth is something important. The number of lesions and the location is relevant as well. So lesions that are more in the outer part of the lung are more favorable for surgery, whereas the ones that are very deep inside the lung may be more favorable for SBRT. And also the presence of extrapulmonary disease, lymph nodes or other organs, they should be taken in consideration as well. So in selected patients, surgery or SBRT have important benefits in controlling the disease. Surgery, there are several pros for surgery. It's a very well-established approach for pulmonary metastases from colorectal cancer. If you have only a couple of lesions, you can do minimal invasive approaches, which leads to faster recovery and easy reinterventions. The local recurrence at the site that you do the resection is not common when appropriate margins are obtained. I'll show you after, it's probably around 20%. It can provide long-term survival, and it does provide also tissue diagnosis. Sometimes it's important to confirm that the nodules we're seeing in the lungs are indeed cancer. And also sometimes can give information for mutation testing. Now, in terms of SBRT, is very well tolerated. Patients don't need to stop. If they are working, they can continue working. There are minimal side effects, 3 to 5 days of treatment, about each 1 hour, and wouldn't preclude other treatments immediately after. So if you have SBRT today and you have to do surgery next week, it's probably okay to do it. There are some areas which are a challenge for SBRT when it's too much in the middle of the chest in this red line. You can cause injury to the blood vessels or to the airway. That's called kind of a no-fly zone. And sometimes if it's too close to the rib, also there is a higher chance of causing rib fractures. It's not prohibitive, but it's something to keep in mind. And like a lesion like this, we would always prefer to go for surgery because it's very periphery of the lung, very easy VATS wedge resection. And some lesions like these are too close to the bronchus. You can see the bronchus here, and that will be a bit of a risk for SBRT because it could cause some injury to the airways. SBRT can also lead to failures. So, this is an example. You do SBRT in October 2017, and then in March 2018, the lesion is bigger. This is another example. This is one of my patients, colorectal cancer, 2016, had this lesion here, received SBRT. The lesion gotten better. And then in 2018, start growing again, and then I had to do surgery to resect that. So it can happen, and I'll show you a few more data on that. This is another situation of a rib fracture after SBRT. There is a crack here. It worked very well for the cancer, but it caused the rib fracture, and it caused a lot of pain to this patient. But I have to say the majority of the patients, they don't have these issues. These are just kind of examples that I wanted to show here. Now, this is one of the best studies that actually compared the efficacy of surgery versus SBRT for colorectal lung metastases. This came out of the MD Anderson. And basically, you can see here, so what they are telling here is that when you receive SBRT in red here, oh, I'm sorry, in red, about 3 years later, 4 years later, 40% of the patients will have the cancer back in that area you treated, okay? Whereas when you have surgery, you have 20% of the patients that will have recurrence in the area that was treated. I'm not talking here about lesions in other places of the lung that could show up, okay? But nevertheless, this tells that removing the lesion, generally speaking, is still more efficacious than doing SBRT. But you know, the odds are with SBRT that you know, 60-70% of the time, you know, the lesion will be not coming back. So it's still pretty good odds there. So when we would consider SBRT instead of surgery, if a lesion require a lobectomy, meaning you have to remove half of the lung, then if a patient has a high chance of future recurrence, we try to spare the lung, and therefore SBRT may be preferable. If you have multiple lung lesions where you could do a minimally invasive surgery, if some of the lesions could be treated with SBRT, sparing an open surgery. And if the patient has multiple medical comorbidities, that is the risk of doing open surgery is too high. And of course, if the patient is not a surgical candidate. Now, in terms of the general principles, you know, when you look at, you know, what is the, you know, overall survival of patients that undergo surgery for pulmonary metastases, and this is for metastases from all cancers, but the colorectal cancer is right at the middle here. So this curve's kind of, it's very well representative of CRC. So generally speaking, we're talking about, you know, about 40% 5-year survival, okay, when patients undergo surgery. Of course, this is a selected patient population that were felt to be suitable candidates for surgery. And of course, there are patients that do a lot better than the 40% because they have less lesions, they have better biology, and there are patients that do worse. So this is kind of an average. One of the important things is that if you have more than 3 lesions, the outcome is worse comparing to less than 3 lesions. So this is, of course, intuitive. The more lesions you have, it is more difficult to control the disease. But you know, that alone, you know, we have to look at other things as well, like the ones mentioned in this paper here. So one of the things, like the risk ratio here, is if it's 1, meaning that doesn't increase or decrease the risk. So for example, this is looking at the survival of patients, okay? So male, female doesn't have any difference. If you have a past history of extrathoracic metastases, let's say you had the previous liver metastases and now you have lung metastases, in fact, is not different than if you never had liver metastases, okay? So the risk ratio is just 1.2. The preoperative CEA level also not important as a prognostic factor, and the tumor size also not too important. Now, the 2 most important features are here, the last 2, okay? So if you have mediastinal lymph node metastases, that's a very, it's a poor prognostic factor for surgery, okay? So if you do surgery in this population, the surgery rarely would help. If you go back and do more, so let's say you do resection of the lung metastases and a new lesion shows up and you go back and do the surgery, that is protective, okay? So you can see here that you decrease your risk, you improve your survival quite a bit. So going back for surgery when new lesions appear is a good prognostic factor. Now, of course, these are only patients that we select to be candidates for repeated surgery. It's not someone that we did surgery today and then 6 months later they have 15, 20 lesions. Those patients are not in here because we just don't do surgery on them. Okay? So this again showing that repeat surgery actually confers a better survival than not doing the repeat surgery. Again, we don't know the role of SBRT here, probably very similar to surgery. As long as you're treating the lesions that are appearing, I think you have a better survival rate. Again, this may have an inherent bias because these are the patients we select for the treatment. Of course, ideally, we should do a randomized trial. When I say randomized trial, is we have a patient with 3 lung metastases, 2 lung metastases, and then you flip the coin and say you go for surgery or you don't go for surgery, right? And actually in the UK they try to do this, and they aim to do 512 patients. At the end of the day, they were able to only do 65 because patients didn't want to be randomized. They, if they were surgical candidates, they tended to just want surgery, but they were only able to do 65, about 30 in each group. So they couldn't reach really any significant conclusion here about whether surgery confers true benefit versus staying just on systemic therapy. Now, we have a very unique setup here that we have this lung metastasis clinic. As far as I know, is the only one that exists in North America. 100% of the patients would be referred to this clinic, patients with lung mets, and we discuss them in a multidisciplinary fashion before seeing the patient. One of the things that we review the imaging of these patients very carefully, and sometimes patients are very surprised because they come refer to us, saying that with a report of a CT scan that has like 3 lung lesions, and then we discuss the patient, we review the imaging, and when we review with our thoracic radiologist, instead of 3 lesions, there are 9 lesions, right? And so we come and speak with the patient, and they say, "Oh, no one told me. I thought I had only 2 or 3 lesions." And that's, again, sometimes they're very small dots, and you have to look, in very much detail to get the complete picture there. And we make a plan in a multidisciplinary fashion. So a few examples of multidisciplinary approach. 76-year-old with colorectal cancer 2 years prior. And then he had these 3 lesions here. You can see it's circled. And then we did SBRT on the right side, lesions, and a VATS wedge on the left side. So he had surgery on one side only. This is 6 months post-treatment. That's the scar of the SBRT. That's the scar of the surgery here. It's just a staple line. This is another patient with 2 lesions, one here in the middle lobe on the right, and another lesion here, quite centrally located in the left lower lobe. And then we did SBRT in the right hilum and a VATS surgery, segmental resection of the left lower lobe. This patient, I did her surgery 6 years ago, and she still, and she had SBRT there, and she's still free of disease. Just saw her recently. She's 81 now. So both surgery and SBRT can result in good control and low toxicity. And of course, there is no randomized trial comparing one to another, so we use clinical judgment, location of the lesions, and so on. And the patient selection is very important, and doing this multidisciplinary approach is also planning is essential. Oops. Now, in some patients, complex surgery can also be performed. So this is a 46-year-old patient, also with a history of colorectal cancer, that had this lesion, lung metastases, one lung metastasis only. You can see this big ball here in the middle of the lung. And this patient, he had declined surgery elsewhere, because when you look at this image, the only way to remove this is to remove the entire left lung, right? And we tend to try to avoid this magnitude of surgery in a patient with lung metastases, because you know what happens when a nodule then show up on the right side, you don't have more reserve for treatment then. And so there is a lot of resistance to treat. So because we have a lot of experience with complex surgery here, we said, yes, the only way to remove this is by removing the left lung. And so we did that. So this is the empty chest here without the lung. But then we got the lung, and we performed the surgery in the lung outside the body. So we put the lung in a bucket of ice with a liquid that we use here for preservation of the lungs for transplant. And we're able to dissect the tumor off the upper part of the lung, because then there is no blood circulating. It's different type of dissection. And then we brought half of the lung back and did an auto transplantation in the patient. So we put part of the patient's own lung back, and he did extremely well. So you can see his X-ray here. The X-ray is now post-surgery. You can see he still has half of the left lung here. And the margins of resection were clear, so we're very happy. This patient had surgery about a year ago. Now, when I showed you that still many patients recur after surgery, one of the main reasons is because when we go for surgery, although we can see the bigger lesions, we can't see these tiny dots here, which are cluster of cancer cells that are already in the lung when we go for surgery. When those cluster of cells go to the lung, we really don't know, unfortunately. Is this something that went when the primary tumor was in place and the cells migrated to the lungs, they stayed there dormant, and then eventually they show up? Or there are cells in the bone marrow that eventually go to the lung even after you remove the primary tumor? We still don't know well how this occurs, but nevertheless, we know that this cluster of cells end up in the lungs. And so one of the concepts is to try to eliminate those cluster of cells, cancer cells that we can't see in the lung. And that's the concept of lung perfusion. This was kind of an idea derived from our system we developed for preservation of lungs for transplantation. This is a human lung being treated, donor lung being treated before being placed in a new patient. And you can give a lot of treatments for that in the system. But of course, for patients, we don't want to take the lung out and treat and put lung back in. We want to simulate this without having to take the lung out. And so that's the concept of in vivo lung perfusion. We started working on this back in 2014, developing the technique, in the lab. And we showed that it was possible to do this. And then eventually we moved to a clinical trial Initially in patients with sarcoma metastasis, was a phase 1 using doxorubicin. And then we start in 2020 or a bit before that, studying in the lab the use of oxaliplatin, also experimentally. And then we first wanted to know what is the dose we need to use, because we have no idea, you know, how much chemotherapy can you give just to the organ, not to the blood of the patient. And so we got this dose escalation done in large animals, and we showed that going up to 40 milligrams per liter seemed to be safe. When we go to 80 milligrams per liter, then the lung got injury. So that gave us a good guidance for our clinical trial in humans. And this is the study design of the trial, 22 patients, colorectal, more than 3 lesions, absence of extrapulmonary disease with some exceptions. And what we decided to do is do this dose escalation. So we do, like, this was a very low dose, one patient only. And then we would go little by little, increasing the doses up to 40, and then 3 patients in each. And right now we are already in the 40, so that's the last dose. And so we are finishing basically this study within the next 6 to 8 weeks. We already have the 3 patients booked for the procedure that will complete this phase. The 20 patients that we have done so far, we didn't observe any chemotherapy-related toxicity in the lung, which was the main goal of this study, okay? So we know now we can give a quite high dose, 40 milligrams, and still we don't see a acute lung toxicity related to the chemotherapy, either in the short term or in the long term. And so this is quite reassuring. And then the idea now, as soon as this study is finished, is to move to a phase 2 trial. Now, what is the main difference between the phase 1 and the phase 2? First of all, in this trial, we only did the perfusion in one lung, not on both. We were worried in the beginning to give to both lungs because we were, you know, if you have toxicity, it's better to take just in one lung. But now that we're quite comfortable that the lungs can tolerate well, the idea is to do on both sides, right? So we're going to do the surgery on one side with the chemo perfusion, let the patient recover. 6 weeks later, we do the surgery on the other side, also remove all the lesions and do the chemo perfusion. We're going to be a little bit more selective in terms of the number of lesions. In the current study, we had patients with lots of lesions that we considered, but now we want to be a little bit more restricted, so we'll be in a range of maximum of 10 to 12 lesions in total, okay? One of the things is we did know how we selected which sides to do. Basically, we selected the sides that had more lesions, okay? So the side that was perfused was the side that had the highest risk of recurrence. Okay. This is basically the concept here. We clamp the pulmonary veins and the pulmonary artery. We put a tube here in the pulmonary artery and 2 tubes in the pulmonary veins. And then we connect to the machine, circulate that special liquid with the oxaliplatin that goes for about 2 to 3 hours. And then we open the clamps and the blood goes back to the lung, okay? This is kind of an example of the incisions that the patients get with this. A patient example of, you know, how the x-ray look. You can see in day 1, sometimes you get a bit of haziness, which is a little bit of water in the lung related to the perfusion, but it's not chemotherapy toxicity. And then day 2 and 3, the lungs already clear. This is another patient, you know, and again, this is a very good example. This patient had 2 lesions in the right lung and 7 lesions on the left. We did bilateral resections and then the perfusion on the left lung that had 7 lesions. His surgery was in March of 2023. Okay, so we're basically close to 2 years now, or 2 years. Now, a few months, 6 months after, he had recurrence in the side that didn't have perfusion. And then we went back and did surgery on the right lung and removed this. Okay. And then he's being again free of disease now for about 2 years. This is not updated here, the 13 months. So he had 7 lesions in the left lung, and they never recurred after the procedure. So again, this is what we want to get eventually. And doing this on both sides, maybe we'll get, this better result. Again, this table is not completely updated for the numbers, but just that you have an idea of the patient population, age 45 as a mean age. So a lot of young people here, male, female distribution. I think now we're about 50%. And mean number of lung metastases is 9. Okay. And then the side that we did perfusion about, I think again, now we're about 50%. And it's being very safe. I think patients leave hospital a week. Some patients leave in 5 days, some patients leave in 7 days, some patients leave 8 days. But it has been very safe. Majority of the patients now did not need any blood transfusion. And this is again, this needs a bit of an update here for the newer numbers. But basically, we are seeing a trend towards less recurrences in the treated lung, despite the fact that the treated lung had more lesions to start with. Now, yes, patients still recur in the treated lung. And I think this depends a little bit of the dose of chemo that was used, how the penetration was in the lung tissue, and also how responsive the specific cancer of the patient is to the oxaliplatin. So I think those things probably play a role on that. Here is just to show when we take biopsies of the lungs, we can see that the higher the dose we give in the liquid, the higher is the dose in the lung tissue. And very importantly, this is the blood concentration of oxaliplatin. It's basically 0, right? So we collect blood during the surgery, day 1, 2, 3, 4, 5, and there is 0 detectable oxaliplatin in the blood. And that's the reason why patients do not develop any chemotherapy-related side effects. This is just a video I'm not going to show here, so we have some time for discussion. But this is available online on YouTube too, you can watch. Now, more and more, we also see patients that have what we consider unresectable disease. So when you say unresectable, means that there are too many lesions for us to be able to remove and leave the patient with a reasonable amount of lung to have a good quality of life, right? So, I mean, sometimes this is a subjective decision, but sometimes it's very clear that there are too many lesions that we just can't do it. And these patients, again, today, the best treatment option is systemic therapy. There is nothing else proved that would be better than, continuation of systemic therapy, different lines of chemo. Some patients may benefit of immunotherapy or other clinical trials. Generally speaking, you know, if you look at like a 5-year survival of someone that you can't resect the lung metastasis is low. So it's about 15 to 20%, 5-year survival. You know, maybe this is maybe a bit better with improvement in some of the systemic therapy. And some subset of patients may do better than others, of course. Each patient may respond differently, but at the end of the day, if you look at all comers, if you can't have the lung lesions removed, that's about 15-20% is your 5-year survival expectancy. Now, as you all know, the liver teams have done for many years now liver transplant for very selected patients with unresectable liver metastases. And last year, there was this randomized trial, which was the best evidence possible to show that in a very selected patients, they would randomize there, flip the coin to continue on chemotherapy or to have chemotherapy and liver transplantation, okay? So they all look similar at the beginning, very strict criteria for inclusion, and then they are just divided based on the flip of the coin. And when you look at the difference in outcomes, it was quite remarkable. So this is you know, overall survival of these patients. You can see in red here, 70% of the patients in the transplant group were alive 5 years later, and 9% were alive in the non-transplant group, in the chemotherapy only. Huge difference. Like many of these patients in the transplant arm had recurrence of the cancer, but they were still alive. And we in our own center here, as you know, Dr. Cypel is leading similar trial, and I see patients from his trial that have recurred in the lungs, and some of them we do surgery, we treat, we continue to manage, and they still keep going, even though they have some recurrence of the disease. And so, you know, when we look at this starting difference here, we also start questioning, you know, should we do or could we do this for lung transplant? And that's where we want to get now with a study that we are starting this year. And this will be kind of roughly the inclusion criteria, patients less than 65, previous diagnosis of MSS, CRC, BRAF negative, treated with curative intent. And then they have unresectable lung metastases, which will be determined by 2 surgeons in our group. And also they have too many lesions even for IVLP. And then the absence of extrathoracic disease. So this is quite important because, you know, when we do a transplant and we put patients on immunosuppression, you know, the chance of the cancer progress faster is quite high. So we want to make sure that we're removing all the cancer that is there by removing the lungs. We do this endoscopy with negative mediastinal lymph nodes. So even though the PET may be negative, we still want to confirm that the nodes are negative. And then patients that are on chemotherapy and have had some radiological response to that. So this is kind of general the guideline here. I think that's it. This is our thoracic surgery group here. There are other surgeons in the group that also do surgery for lung metastases, and we have all an excellent team here. So thank you, and I'll be happy for any discussion.